what you have to make sure is, if you have a patient who has KTS and you think that they need either some surgical procedure like stripping of their lateral marginal vein, or you're going to do any ablative therapy radiologically to the lateral marginal vein, you must always identify that they have a patent deep venous system in that extremity, because if they do not have a patent system there and you go on and remove the lateral marginal vein, you will then render that limb chronically swollen for the rest of their lives. That lateral marginal vein is the venous outflow for that extremity when they don't have a patent deep venous system, so you must identify it well. This is a girl actually with chronic recurrent ulceration in her leg. She has Klippel-Trenaunay syndrome. On her MR, you can see on the T1, this is the area of the ulceration. Here's the fibula, here's the tibia on this axial scan. And in fact, this is the same side as the lateral marginal vein. And on the venogram, which actually we did several ways before actually I punctured the femoral vein, and then when we puncture the femoral vein, if you just put some simple pressure just above your puncture catheter, just above the catheter or the sheath, inject it, it'll fill it in a retrograde fashion, and you'll see that the femoral vein ends here and there's no femoral vein, it's atretic, so we could not go on and do any endovenous laser therapy for her, which would have made her leg significantly worse. She does wear a compression stocking, but this ulcer takes months. It sometimes takes 6 or 8 months to heal. She's had recurrent ulceration over many years. I have a small group of patients with KTS who've got venous hypertension and varicose ulceration in their legs. And so the other thing you can do is, if you're bringing a catheter from the opposite femoral vein over the iliac vein or down from the jugular, when you get the catheter down into the femoral vein and you want to fill the vein, and you'll be able to identify the level of the atresia. But sometimes it can be so difficult, and therefore puncturing, for example, the tibial veins, you have to put the patient prone on the table, puncturing the tibial veins, filling them so the drainage goes more in a normal fashion. You can identify the deep system. So there are many problems in KTS that we see: overgrowth, bleeding from the skin, lymph leakage, lymphatic infections, thrombosis, and extremity pain. And extremity pain is a real problem in KTS patients, and not forgetting in children. Children can get growing pains as well, but there are a variety of causes of extremity pain that we see in KTS, including chronic venous insufficiency, cellulitis, DVTs, thrombophlebitis, problems related to intraosseous venous malformations, arthropathies, because if they have the venous malformation in the joint, they can bleed, usually around at the knee, and neuropathies. Patients with KTS can have neuropathic leg pain, for example. And here is one boy with some superficial blood clots in these veins, giving rise to recurrent pain. And actually, he had these so frequently, we decided to put him on low molecular weight heparin. I'm going to actually just show you this MRI scan and show you that what you're looking at on MRI with all these little horizontal structures on this coronal T2 weighted MRI are actually all venous structures. They're not lymphatics at all. When you look at the venogram, it corresponds to these areas here. And that's just a bit of a carcinoma for radiologists, I think, actually. And I'm just going to, I'm sorry, I think we've just gone. I just wanted to briefly end on Parkes-Weber syndrome. And some people get Parkes-Weber and Klippel-Trenaunay slightly confused, because in Parkes-Weber syndrome, like in Klippel-Trenaunay syndrome, there is overgrowth of the extremity. You can also get what used to be described as a capillary malformation, but it's actually a pseudo-capillary malformation, probably because of the fistulae in the arteriovenous fistulae affecting the skin. And the other thing that you can get in Parkes-Weber syndrome are varicosities because of the shunts through the arteriovenous fistulae. And if you look on an MRI, you'll see little flow voids around, for example, around the knee, which was from this girl who has some overgrowth, and these flow voids are due to the high flow shunts in the arteriovenous fistulae. You don't need, this is a clinical diagnosis. If you feel this leg, unlike the leg in Klippel syndrome, this leg will feel hot. when you feel it. And you can make that, if you want to confirm the diagnosis, the easiest way is to just get an old-fashioned Doppler probe, not an imaging Doppler, but just an audible Doppler, and run it around the leg, particularly where the vascular stains are, and you'll hear evidence of fistulae. And this is what the fistulae look like, certainly in this girl. Here is the angiogram, here's the popliteal artery, abnormal vascularity due to the fistulae, and early draining vein, early drainage into the popliteal vein here. And on the lateral view of the angiogram, you can see that the abnormal communications are actually nearly all intraosseous in this girl. But the quickest way to make the diagnosis is just put a little Doppler, an audible Doppler probe on the leg, and once you've felt the leg is much hotter, just put that on, and that will confirm the diagnosis. The fistulae in Parkes-Weber syndrome are either macrofistulae or microfistulae, or a combination of both. Radiologically, we cannot treat any microfistulae, and some of the macrofistulae may be suitable to be treated. What we know is that in Parkes-Weber syndrome, there are sometimes combinations of these capillary changes in the leg and arteriovenous fistulae, but you also may, some people call them capillary AVMs as well, and also you may have underlying lymphatic abnormalities in Parkes-Weber syndrome, as you can in KTS. Sorry, no, it's okay. And really what I wanted to tell you was that in babies and young infants, you may not do an angiogram, you may not identify the fistula easily. All you see is the hypervascularity and prominent drainage, early drainage into veins. This is a profunder arteriogram in the leg of this baby, whereas in the older child, you actually may identify the fistulae, but in the babies, you won't. So in Parkes-Weber syndrome, we have a cutaneous pseudocapillary malformation, hypertrophy of the limb, AV fistulae, which give rise to these signs clinically, and some superficial varicosities. Most patients with Parkes-Weber syndrome we do not treat as interventional radiologists. I think I should stop there. Thank you.